Hello and welcome to those of you who are joining. We're just going to give a minute or two for folks to get settled in. So this is your last chance for a coffee or bio break before we get started. Thank you and welcome. Hello, folks. We're just giving another minute for folks to join. Please feel free to introduce yourself in the chat, and then we'll get started once we've hit a critical mass of folks. Thank you for being here. All right, excellent. I was secretly just waiting for us to hit 300 participants, which we have. So we're going to get started now. I see that folks are using the chat to introduce yourselves. So please feel free to continue to do that while I welcome you all to our webinar for today on clinical high risk for psychosis, screening, diagnosis, and risk assessment. My name is Adam Vieira, and I am the task lead with the National Training and Technical Assistance Center for Early Serious Mental Illness. And before we get started, I'd like to just give you a little bit of orientation to our Zoom platform for today. And for those who can't see me, I am currently a Latino male with dark hair, wearing blue glasses and a red and black check shirt. So next slide, please. All right, so just a couple of notes before we really get started. This presentation is being recorded. We will be making the presentation slides and recording available afterward via email. So after the webinar, keep your eyes in your inboxes and we'll make sure to send these once we've had a chance to compile them. During the presentation, you're welcome to submit questions and comments through the chat and through the Q&A. We have a number of folks who you'll see who have the ESMI TTA Center in their names. Those are folks you can reach out to if you have any questions and need any assistance throughout the webinar. So without further ado, I'm going to pass it off to our project director, Dr. Preethi George.
Thanks, Adam. Thank you so much. And thanks everybody for attending. We're so excited to share this presentation with you on screening, diagnosis, and risk assessment in clinical high risk for psychosis programs. This is such an important topic, and we are thrilled to have experienced presenters today to share practical and relevant information that you can use in your work. So for our webinar today, we'll have a slide presentation with information on screening, diagnosis, and risk assessment. We'll then have a panel discussion with SAMHSA CHR-P grantees, which will be great. And then at the end of our webinar, we'll have a Q&A session. And we'll be following that with closing remarks. So please feel free to include any questions that you have in the chat. We'll get to them at the Q&A session at the end. So I have the delightful pleasure of introducing our presenter, Dr. Barbara Walsh. Dr. Walsh is the clinical coordinator for the Prime Clinic at Yale School of Medicine. She oversees the clinical evaluation and treatment performed on young people at the clinic, and she's responsible for providing psychoeducation on early warning signs of serious mental illness in young people to a wide variety of communities. She's also responsible for training professionals both here in the United States and also abroad on proper use of assessment instruments use to diagnose the early warning signs of serious mental illness in young people. So we are so honored to have her here with us today. So please welcome Dr. Barbara Walsh.
Thank you so much for that wonderful introduction. And I just want to say it is certainly an honor to be here with all of you today. I am the clinical director of the Prime Clinic at Yale School of Medicine, and we have been a CHR specified clinic for about 30 years now. And I am a firm believer that we do very difficult work in this field. And the first thing we need to do is mentor one another and share what we've learned through our experience. So I am happy to share all of Prime's materials and templates. I am in no way implying it's the right way or the only way to approach things. But if anything we've learned over the past 30 years can be helpful to you, we are more than happy to share that with you. Next slide. So these are the learning objectives for today's webinar. We're going to introduce you to the screening tools most commonly used for detecting people who might be in need of a SIPS assessment, and how you utilize your resources, your staffing to make all of that possible, and how you develop your referral pathways, and how you determine who gets what type of treatment if there are coexisting disorders. Next slide. So the Prime Clinic, as I mentioned, has been around for 30 years. And one of our first objectives was to help educate the public on what exactly is a risk assessment, what is clinical high risk of psychosis, because believe it or not, it was not something that was very commonly known or even taught to professionals, let alone lay people. So we developed an outreach program, and the Child Welfare League of America came in and evaluated it. And what they found is that in mental health clinics, about 20% of individuals who present there will actually meet CHR criteria, but only about 3% were actually being identified. So they really emphasize the importance of community outreach and how it can alter the mental health journey for these young people. They absolutely encourage that the outreach work be duplicated so that adolescents and young adults would not fall through the cracks, and that they would be identified at being at risk for a psychotic disorder as quickly as possible. Now, I want to emphasize that the purpose of outreach is not to establish the diagnosis of CHR. It is to educate individuals in the community who spend a lot of time with young people, who are going to be those first people to notice when a young person is going off the rails. It is our job as CHR clinics to make the accurate assessments. We just need to educate people what to do when they notice these young people struggling. Believe me, I've been with the Prime Clinic for over 26 years, and to this day, there are still people who don't know exactly what I do. But what they do know is if I'm having trouble helping a young person with their mental health, I call that Barbara person because that's what she does. And that's the message you want to get out in your community. We are a clinic that specializes in this work. We are here to help you. This is how you reach us. Next slide, please. So wherever you are located geographically, you have to first determine who are the stakeholders in your community. Who are those individuals that are going to notice these young people struggling? So in my particular geographic area, we have a lot of colleges and universities. So one of the first things I had to do is get in front of the resident assistants and the resident directors, the people who are going to notice young people isolating in their dorm room, not interacting with the other students, perhaps being suspicious of the other people in their dorms. They are a wonderful resource for referrals for us. I reached out to all the middle schools and the high schools in our area, particularly to the school nurses. When young people are struggling with CHR symptoms, they have great difficulty staying in class, focusing, and attend. So what do? They go down to the nurse's office, and nurses get to know these young people very well. So you want them to be aware of your services and how they can access your services for those young people. Now, depending on where you are, whether you're urban or rural, your stakeholders might look different. You're going to want to reach out to boys and girls clubs in your area, the Ys, the 4-H clubs, whatever is pertinent to your area and where young people in your location spend a lot of time, you want to reach out. So we identified what we called our buckets of recruitment, and then we established different methods for reaching out to each of those stakeholders, because it does need to be different. Now, one of the things I want to point out to you, if you are a SAMHSA grantee, SAMHSA allows for reporting of primary outreach and secondary outreach. So your primary are your mental health clinicians and psychiatrists and psychologists, but your secondary include all of those schools, colleges, universities, and youth-serving organizations that you can reach out to. So it still counts in that recruitment data. Okay, next slide. And when I talk about customizing your outreach, clearly, if you're trying to reach out to a very busy private practice of psychiatrists, you're not going to walk in there and offer them an hour-long presentation. They're just not going to have the time to do that with you. So you want to have a whole menu of outreach available to you. The very first thing that we do is twice a year, we do a massive mailing offering free staff training. So we will go into any organization's regularly scheduled staff meeting and do a presentation on the early warning signs and symptoms of psychosis in young people, and to educate them about the services that our clinic offers and how they can access it. We do email blasts to all the schools, colleges, universities, private practice practitioners, mental health clinics. Every week, I hold a lunch and learn session where I invite other area professionals to brown bag their lunch, come listen to my presentation for a short time, and then engage in questions, answers, and conversations with their colleagues about this work. We do in-person presentations to any group, whether it's parent organization within a school, NAMI, mental health facilities, colleges, universities. We will go in and do free presentations. We have quite a presence on social media where we routinely put up information. We offer online surveys on our website. We also put our Prime Clinic questionnaire in doctors' waiting rooms. Very interesting fact. Research shows that females between the age of 16 and 25, the only physician that they see on a regular basis is their gynecologist. So we reach out to gynecologists and OBGYNs and leave our survey in their waiting room. So if anyone is experiencing mental health concerns, they can take the survey and reach out to us. And then we also offer universal screening. What that is we collaborate with area mental health clinics, and in their front door policy, their intake for all their participants, we include the Prime Clinic 12-question questionnaire. And if individuals pop positive on that questionnaire, they are immediately linked to our clinic for a SIPS evaluation. So be creative, customize your outreach methods to the population that's best going to be able to serve your clinic. Next slide. Now, what is going to make these people engage with your clinic? Let's be honest, we're all very busy. We have huge to-do lists, and we don't want to add anything to our to-do list unless we recognize how it's going to help us be better at our job. So you need to be very clear. What added benefit do you have to offer these referral sources? And the first and foremost one is the diagnostic clarification that a SIPS evaluation can offer to someone. And you want to be very upfront and clear with that. And I have to tell you, even when a person doesn't meet CHR, and I can't take them into care at our clinic, those referrers still leave feeling like they received something positive from their interaction with me. And that is me providing them with resources for other clinics or physicians that I feel might better help that particular patient, for clarifying for them what exactly is a risk assessment. What does it mean for that young person? Believe it or not, families, professionals are not very familiar with a risk assessment, and they don't really understand what it means. So a big part of that outreach is educating the population exactly what is a risk assessment. What does it mean? How does it differ from a diagnosis? And that is very valuable information to people, especially in moderating their anxiety. We offer a written summary of the SIPS evaluation. Now, you don't ever share a SIPS with outsiders because there are so many nuances to making ratings that if you just shared the SIPS, you would open it up for misinterpretation and potentially misdiagnosis and treatment of young people, which you would never want to do. But we have a template that we are happy to share with anyone that summarizes the evaluation, so it is very clear to people what the evaluation discovered. And we always share that with the parent or the patient, and then they are free to share it with whoever else they want. Or if they are willing to give us a release of information, then we will share the evaluation with their referrer. And you must be prepared ahead of time for recommendations for referrals. You want to have your list ready. So if the person presenting to you doesn't meet CHR, then you are going to be able to refer them perhaps to the OCD clinic or the anxiety clinic or the depression clinic. So be prepared ahead of time. Do your due diligence so that you have those referrals available. Next slide, please. And what is the benefit to the young person coming in for the screening? Well, if you engage them prior to severe illness developing, they are much more likely to accept treatment. And as we all know, when a person is an active participant in their treatment plan, that treatment plan has a much higher probability of being effective. It helps to foster the early development of a therapeutic relationship. It allows that individual to gain access very rapidly to appropriate treatment, which results in a reduced duration of untreated psychosis. And we all know from the research that reduced DUP improves the prognosis of at-risk individuals. Next slide, please. Again, there is some resource planning on your side before you start your outreach. You want to be prepared with your list of resources for FEP, first episode psychosis, if the person does indeed meet psychotic level of intensity on the SIPs. You're going to be prepared with other resources for other various mental health concerns if they don't meet CHR, but you clearly hear things like depression or anxiety. You want to have those resources available as well. And as I mentioned, you want the person doing this to know how to provide psychoeducation on what a risk evaluation is, how you explain it to the patient, their families, to referrers, and other treaters and providers in your community, and exactly what and what it doesn't mean. The last thing we ever want you to do is say, well, they don't meet criteria, so you're all done. That is never true. We know that CHR is fluid. It's unraveling. We want to reassure the person at this time, this individual does not meet the onset, the intensity, the frequency, the area of distress and interference to meet the criteria. But if new symptoms develop or these symptoms worsen, please contact us immediately and we will reevaluate the person. Then you also need to be educated how you explain what a risk means. And you also have to be comfortable, if they did indeed meet psychosis, being able to share that outcome with them as well. Next slide, please. There are screening tools that are most widely used. The first one is the PQB, the Prodromal Questionnaire in its brief version. Another one is the Prime Screen, which is a 12-question questionnaire. And then there is a more general phone screen measure. Next slide, please. The PQB is 21 questions. It evaluates experiences that have occurred in the past month, and you are provided with scoring standards. The PQB is an effective, efficient self-report screen for prodromal psychosis syndromes that is meant to be followed by a diagnostic interview like the SIPs in a two-stage evaluation process. Dr. Rachel Lowy and Dr. Tyrone Cannon are the authors of the PQB. So if you have specific questions about that, you can either reach out to me or to them. Next slide, please. The PRIME screen was authored out of the PRIME Clinic at Yale. It is 12 questions that assess the attenuated psychosis symptoms. It's been validated in multinational symptoms. It is available to everyone. There are scoring standards available as well. And again, the important thing about the PRIME screen is there does not need to be a licensed professional using this. It is meant to be used as a self-report or by lay persons. Dr. McGlashan's, Miller, Woods, and authored this at PRIME. Next slide, please. And then the third measure is a more general phone screen measure that we developed at PRIME when we get the opportunity to have a phone conversation with the referral source or the patient or their family member. It can be used regardless of who is referring the individual. It helps you establish a contact for ongoing consultation. It tracks sources of your referrals so you know where to buff up your recruitment. It also identifies areas that might need further explanation, gives you an opportunity to establish rapport with the person, and sets up expectations early. And again, we are very happy to share that with you. Next slide, please. These are some references, not only on the phone screen, but of all the screening methods that I offered to you, the PQB and the PRIME screen. Next slide, please. Now, there are assessment tools that have been standardized for making the diagnosis of CHRP in young people. There are 4 of them. The CARMS, which was authored out of Australia, was the very first standardized assessment for this purpose. The SIPS, which is the most widely used of the assessments, that was authored out of Yale. And then the newest one, the Psychs, which is actually a harmonized version of both the CARMS and the SIPS. So it allows for diagnosis based on criteria identified in both of those assessments. And then there is the mini SIPS. The mini SIPS was also authored out of Yale, and it was designed specifically for very busy private practice situations where people aren't sure, is perhaps psychosis a diagnosis that should be on the table? And it is very down and dirty, done very quickly. Next slide, please. So all of the assessments are semi-structured. They are used by mental health professionals and researchers. They identify help-seeking young people who are at risk of developing psychosis. They track a range of psychopathology that will identify the onset of first episode psychosis. For the CARMS, the SIPS, and the Psychs, the individual must have a minimum IQ of 70. The time to administer these takes an hour to 2 hours, and there is very specific training required. The mini SIPS also requires the minimum IQ of 70. However, the time to administer is 15 to 30 minutes, and there is a quick 30-minute training available online. But please do remember, the mini SIPS is never going to give you the detail that the SIPS, Psychs, or CARMS will. And it will not be able to track the nuance in improvement or decline in repeated visits over time. Next slide, please. The age ranges for these various assessment tools are listed here. The CARMS is 12 to 35. The SIPS is 10 to 45. The Psychs is 12 to 45. And the mini SIPS is 12 to 45. Next slide, please. And just in conclusion, I would like to add that at-risk research in psychosis provides a rationale for service provision to those individuals in need of help who could not previously access it. And it provides the possibility of truly changing the trajectory in a very positive direction for those with vulnerability to psychotic illness. I also want to point out to you that the pre-screening methods that I described to you today are never intended to be given to a healthy population. You don't walk into a sophomore class of high school and give it to everyone. They are specifically designed for help-seeking individuals, individuals who are having some type of mental health concerns or emotional difficulties, who are concerned and who would like some guidance and care. And then you do that sub-screening information to help you determine if they are indeed a good candidate for the semi-structured diagnostic clarification evaluation. But pre-screening is never meant to diagnose. It is always to determine if a further evaluation is warranted. The CARMS, the SIPS, the Psychs, and the mini SIPS are the assessments used to make the diagnosis. And then, of course, that would be followed up with feedback on the outcome of the assessment, treatment recommendations for whatever diagnosis they missed, and then an evidence-informed stepped care approach to treating that individual if they do indeed meet criteria for CHR. I want to thank you all for your time and attention. And again, please, there is my email address. If you have questions, concerns about anything I've presented, if you would like me to share any of our materials with you, I am more than happy to do that. Please just reach out. If you're struggling with your outreach or conducting SIPs, I am more than happy to try and troubleshoot that for you. Over the past 26 years, I have consulted with many clinics around the world, and we've gotten really good at identifying what's not working well. So you don't have to suffer through the mistakes we've made over the years. We're more than happy to share that with you. Thank you very much. And now I'm going to turn our presentation over to my esteemed colleagues who are also very active and engaged in this work. From New Jersey, first up is Sue Rigliano and Benjamin La Mendola.
Thank you, Dr. Walsh. And we want to thank you so very much for inviting us today to participate in this webinar around this very important work. Dr. Walsh has trained many of us in New Jersey over the years on the SIP, so we want to thank her. It's been very helpful. Again, as Dr. Walsh said, my name is Sue Rigliano, and I am the project director for CHR services in New Jersey, which we call NJ Promise. The grantee is New Jersey's Department of Children and Families. I work at DCF in the Division of Children's System of Care. And our CHR program has been operating since 2018. We were among the first cohort of SAMHSA awardees stand-up CHR clinics around the United States. At that time, New Jersey had 3 provider agencies who were already delivering coordinated specialty care to the first episode psychosis population. So we co-located our CHR clinics with each of the existing coordinated specialty care programs. Our CHR service is statewide in New Jersey, with each of our 3 provider agencies serving a region of the state. And each clinic is staffed with a part-time program coordinator who also operates as the outreach specialist. We have a part-time prescriber, a part-time case manager, and a full-time clinician. Each clinic can treat about 20 individuals at a time, for a total of about 60 across the state. We are proud to say that since 2018, we've served about 200 individuals in NJ Promise. All 3 of our CHR clinics sit within large behavioral health agencies, so many of our referrals come from their outpatient clinics that are connected to the CHR clinics. Here in New Jersey, we also have a statewide children's system of care consisting of care management organizations and children's mobile response units in each county. So those are also some very common referral sources into our CHR clinics, and these are entities that we regularly outreach to. We use the Prime screen here in New Jersey. So typically individuals who are newly referred in are screened by the outreach specialist. For individuals who are screened out via the Prime, we have easy access to refer them to coordinated specialty care, as I said earlier. So that would be for individuals who already have been diagnosed with a first episode of psychosis and they are above the age of 15. We're fortunate to have another option here in New Jersey, which is the PEACE program. And this is a small clinic for children under the age of 15 who have been diagnosed with psychosis. The PEACE program is operated through Rutgers University. It is not funded by SAMHSA or by New Jersey Department of Children and Families. However, the director of the PEACE program is on our SAMHSA grant here in New Jersey as our clinical coordinator. So there's ongoing collaboration, and all providers for psychosis spectrum services here in New Jersey work together really effectively. In terms of individuals who are not eligible for NJ Promise due to psychosis, as I said, we have a nice continuum of care and adequate services to refer them to. For individuals who are eligible based on the Prime screen, they are then scheduled for a SIPS assessment, which may be done by our clinic's outreach specialist or the clinician. If they're screened out for CHR services after the SIPS assessment, the same process would apply as how we would operate after a Prime screen, either to coordinated specialty care or the PEACE program if we have psychosis, and those without risk for psychosis are referred to an appropriate outpatient service depending on their needs. Once appropriate individuals are enrolled into NJ Promise, they would be assessed using the SAMHSA NOMS tool, which is National Outcomes Measures, and then they would begin stepped care. In our clinics, we administer the SIPs every 6 months while individuals are engaged in treatment in order to monitor symptoms and assess the need for continued stay in the program. During our most recently completed federal fiscal year, we received 67 referrals. 48 of those individuals were screened with the Prime screening tool. 27 went on to be assessed via the SIPs, and then 21 were enrolled into our CHR program. So that gives you an idea of kind of the funnel process of how individuals go from referral into enrollment. So that is a little bit of background information about our CHR services here in New Jersey. And I'm now going to turn it over to my colleague, Ben Amendola.
Hey, Ben, it looks like you're on mute and we can't hear you.
Yes. Okay. Thank you. I was saying, I don't think I've ever talked to this many people at the same time. So this is a little new for me, but I thought just for a few minutes, I would share just a few practical tips on working with this population and maybe a bit on how to have conversations with the client and with the family in a way that feel natural and don't make the client feel weird or like they're going crazy. Listening to Barbara talk, the first thing that I was thinking was, for those of you out there, this is very new to them, it may be helpful to check out the Prime screen, check out some of those assessments, because there may be some questions in those assessments that you can add to your initial assessment that you're already doing, that may get you comfortable with asking questions that may be a little bit different than just your regular initial assessment. Some of those are getting to the theme of, if a person or a client you're working with is feeling like their mind is playing tricks on them, or they're feeling like they're going crazy, or they're hearing things, or there's just something going on that they don't know how to explain. So if you can check those out, it may make you feel more comfortable asking some of those questions. And also, it gives an opportunity for clients and young people to talk about symptoms that may feel strange or they've never had an opportunity to talk about. So what Barbara was saying about doing the full assessment can actually be therapeutic, because it gives that opportunity to talk about things that are kind of strange or hard to talk about. And transitioning a little bit into how you would actually have this conversation with a client or a family, what I'll say to them is that actually these symptoms are so common, that the federal government is funding early intervention programs for symptoms like this. So it's not anything to feel strange about. It's common. Sometimes we hear voices. Sometimes we have strange thoughts. Sometimes we can't totally explain what's going on. So normalizing it is important, and you might look at it as a spectrum. We've had experiences, most of us, hearing our name being called, or maybe feeling a little paranoid that someone's following us on the road, there's someone behind us. So there's a spectrum of these types of symptoms, and when I'm having conversations with clients and families, trying to normalize it and give an opportunity to open up a conversation about it. Also, and speaking a bit to those out there who this may be new to them, to remember to stay calm when these symptoms are being expressed to you. It may seem a little bit out of your competency, or psychosis sounds scary and I don't know what to do. But just remembering to stick to the fundamentals and think in common sense that these symptoms may not even be the most important thing that's happening for the client. There may be things that are happening that are more important to address. So the symptoms are still important, but remembering there may be family conflict, there may be social things going on. So in other words, thinking in systems, seeing the whole picture, and treating this individual in context as a unique person, and not necessarily getting overwhelmed by the fact that they may be hearing voices or having strange thoughts. We want to stay calm and stick to being curious about their experiences and learning about it, and staying calm about it. There's resources out there if it feels like it's something that you can't handle. And this is a good step in learning more about this issue. I guess the last thing I would say would be that it's early intervention, so we want to be hopeful about it. And there's a lot of research out there that this is effective, and someone's getting involved with help early. So that's a great thing. And we want to keep that attitude of learning, hey, they're here, they're getting help. We're giving them an opportunity to find out more what's going on. That's the purpose of some of these assessments. And they're catching it early, and things can get better, and keeping that attitude. So that's some of what I wanted to share. And yeah, thank you for the opportunity to share some of my experience.
Thank you very much, Sue and Ben. That was wonderful. And I would just like to emphasize that, you know, one of the things about conducting an semi-structured interview is you must introduce it to the young person, that you have to ask everyone the same questions, that the questions aren't designed just for their experiences. And I can honestly tell you, young people stop me halfway through the SIPs and look at me and say, do you mean there are enough people out there experiencing these things that you have written down these questions? And I say, yes, this is what I do all day, every day. And you can immediately see the relief on their face. Why? They've been afraid to share with people what they are experiencing. Therefore, they think they're the only ones having these experiences. And as Ben said, when you normalize it, that other people experiencing it as well, it becomes much less frightening. So now I would like to introduce our esteemed colleagues from Massachusetts, Amanda Weber and Emily Gagan.
Hey there. Yeah, thanks for having us. It's great to be included as part of this panel. I'm going to talk a bit about the work that we've been doing in Massachusetts to improve screening and identification, and in turn reducing the duration of untreated psychosis. I'm going to talk about a statewide program that we have, and then Amanda's going to talk more about the clinical programs that are treating folks that are identified, and the evaluations that they do in those clinics. So our program is called Empath. It's the Massachusetts Psychosis Access and Triage Hub. And the idea is that Massachusetts has quite a number of both early psychosis or first episode programs, as well as a few CHR programs. But we were finding that families were having trouble knowing where to go next. If they were told by a provider, or, were in a recent hospital stay and had been discharged, to know where to go next or how to access these programs. It was difficult, feeling kind of adrift in the system to some degree. Also, all of our programs have somewhat slightly different criteria in terms of catchment area, age range, things like that. So Empath was created to kind of be a front door to those services. So we hear from families, occasionally young people themselves, but most often families who are reaching out to find out where they should go next. They have a young person in their family who's experiencing some level of distress. And so we talk with them about, what program might be the right fit. On the CHR side of things, we're trying to gather enough information to then decide, yes, it sounds like a further CHR evaluation would be a good fit. So then we'd be referring to one of our CHR clinics. And we also offer support all throughout that process, because, these services are sometimes in short supply in terms of evaluation slots and things like that. Sometimes there can be a wait list. And so Empath stays in touch with folks throughout the process of waiting for that evaluation. Empath is not doing treatment, so we're not providing therapy or prescribing meds in the short term, but we're providing support. I'm a psychologist. We have an LMHC on our staff. And then we also have a family partner and a young adult peer mentor. each with their own respective lived experience, that is also available to talk with families, talk with young people as they're moving towards that next step of getting an evaluation. And then the other side, or the other piece of our work, is doing a lot of what Barbara was describing in terms of outreach. So we do a lot of presentations for exactly the categories that were being described: outpatient mental health, primary care, inpatient folks, school counselors, college counselors, to help improve their understanding of psychosis and identification of young people who might be having some of these experiences. We also do one-on-one, or sometimes several people are involved, but individual consultations where we talk with a provider or perhaps a team of providers about a young person that they're currently working with in whatever setting that might be: college, high school, primary care, general outpatient mental health. And we meet with folks for that consultation to then think through with them what might be going on. That, you know, sometimes what we're hearing, the provider has started to wonder, is this psychosis? And actually what we're hearing is very perhaps trauma focused, for example. And so we're making suggestions to the providers to say, have you asked some of these questions? Maybe, you know, look into this trauma focused resource, stay in touch with us. We're happy to continue talking about the client and can help, you know, point folks towards an evaluation if that becomes necessary. We've been thinking about this as trying to help providers be thinking about psychosis informed care. It's a term that we've tried to use to think about how we can help providers in the community have more understanding and honestly confidence to talk to young people about the experiences that they're having, and have a better understanding of, and not feel like this is an immediate, oh, I have no experience with psychosis, with clinical high risk, and so I must immediately refer this person out. I'm no longer the appropriate provider, but rather continue to be able to work with this young person as empath helps to figure out what the next step would be. I think that about covers all of that. We're a new program. We've only been around for about 2 years, but we are continuing to expand. I would love to hear from folks if there's anyone in other states that's trying to do something similar in terms of kind of a coordinated statewide effort. Would love to talk more. Also, if folks want to just talk more about it, if they would like to do that in their state. We're also giving a presentation at the American Psychiatric Association in May at their annual conference, if folks will be there for that. Would love to see folks there, but I'm going to pass it on to my colleague, Dr. Weber, to talk more about the work in Massachusetts.
Hi, everyone. Thanks for being here. I'm the clinical director at CEDAR. CEDAR's been around for about 15 years. We are based in the Brookline Community Mental Health Center, so we hold on to all of those sort of community-based values. Our program is staffed by a clinical coordinator, a couple of LMHCs, some part-time psychologists, 2 part-time child and adolescent psychiatrists, and then multiple trainees across different levels. I'm going to talk about some of the work that we've been doing under the SAMHSA CHR-P grant that we were awarded 3 years ago. We submitted our application as a collective of people. So we are partnering with the other 2 programs within the state, so Reset at MGH and STAR at McLean. And what we are doing is working together to streamline care into treatment. So we do a lot of referral sharing. We do a lot of work on screening and then sharing with the other clinics so that people don't have to be screened at multiple points. And we also do sharing across evaluations as well. So one of the clinics may evaluate, and then we will share our evaluation with other clinics. And if they're more appropriate, because there's some subspecialties. So for instance, MGH might take more of the medically complicated folks, or we might take the individuals who solely speak Spanish, since we have the most robust Spanish speaking abilities in the state. So We also, along with collaborating across referrals and screening and treatment, we've sort of come together as a collective for training. So we do SIPS training twice a year as a collective. So any new staff, any new program that's trying to develop in the state, which there are 3 of, any new trainee will get trained by Dr. Walsh on the SIPS. We do refresher trainings every year. We do advanced SIPS training every year. And we also have a SIPS consultation meeting every week that all of the programs or all the clinicians are welcome to join. And part why we're doing this is to have some fidelity to the SIPS, but really to understand and make sure that we're holding on to the complexity of this population. And what I mean by that is, if people are coming into our door and there's sort of this signal or this risk signal for psychosis, there's also usually other things going on as well. Might be social anxiety, might be family stress, school stress, bullying, trauma, etc. And so we are trying to work together to understand all that complexity and then hold it together as a state of people. Sorry, I'm looking at the time and I want to leave time for questions. So give me a second while I'm looking through stuff. I'm going to name really quickly some of the challenges we have with screening and referral and assessment. In Massachusetts, we have a particular bottleneck at referral and screening and evaluation. There are many more spots for treatment than we can get through the door. As Dr. Walsh was mentioning, the SIPS is particular and specialized, so very few people actually have the expertise in delivering it. But also, it's not just the SIPS that we're often doing, right? We're doing full comprehensive diagnostic assessments because, again, we are working with individuals who are often under the age of 18. They are developing brains, they're developing people, they're developing identity, they're multi-stressed, lots of comorbid conditions. And so we need to do both these SIPS and a comprehensive diagnostic assessment so that we can understand if the person's appropriate for treatment within the clinical high risk centers, or if something more along the line of an OCD type of intensive treatment is more appropriate, and making sure that the families receive those recommendations as well as proper feedback. So we often spend a lot of time on these assessments. In the state of Massachusetts, all the clinics are doing 3 appointments to make sure that we are getting a full understanding of these folks, which does create a bottleneck. We have been trying to work on this as a state level to figure out ways to get this to move a little bit faster. One clinic that is beginning to start up in the CHR-P services in Massachusetts that we are helping is Edinburgh, and they are going to just do evaluations and then referring out folks for treatment to the other CHR-P clinics to sort of help with this bottleneck that we're experiencing in the state. I think the other thing that we're beginning to try to figure out as a state is how do we make sure that we are more culturally competent or responsive to the folks that we're seeing. So in Massachusetts, we have a large immigrant population, and so making sure that we can deliver services across many languages and many folks. Adam, I will stop because I see you.
Thank you so much. So sorry to come on, but I know we only have a couple of minutes left, and I just want to take a moment to first of all thank our presenters and panelists for the incredible information that they shared. I also just want to acknowledge that we do have a number of questions that we have been tracking. We will be sending out responses, and we will be also working with Dr. Walsh to identify links to all of the screening tools that she mentioned so that you all have access to it along with the slides to this webinar and all the other information that's contained within. We'll also be sharing the recording, so if there's anything you want to listen back to, you will have that opportunity. I just want to close by asking you all to complete our evaluation, which you will see linked here. I'll also put the link in the chat. And then finally, I just want to close by sharing that this is part of a larger series through the ESMI TA Center. So our next webinar in January will be a continuation of this discussion focused on clinical high risk for psychosis stepped care. So please stay tuned for that. That'll be taking place January 21st at noon Eastern time. And the link to register for that will be sent out in the next couple of weeks. So With that, I just want to thank you all immensely for being here, for being so engaged, sharing your questions. We will be in touch afterward. And if you have any questions, please do not hesitate to reach out to us. You'll see the email and the link to our website here on this slide. Thank you and happy holidays.
And Adam, I just want to add a thank you to you and your entire team for putting this together. You guys work so hard. Thank you very, very much.
Thank you. That's really lovely of you, and I really appreciate it. Everyone's feeling the love. Happy holidays and have a wonderful day.